Thanks, everybody. This is the Cancer Prevention and Wellness Program sponsored by the Cancer Survivors Park Alliance. I'm your host, Jeff Jaguar, and we will get started in a couple minutes to let everybody get on board. And again, thank you for taking time out of your day to participate. Again, thank you for joining us. This is the Cancer Prevention and Wellness Program. Tonight, we're going to hear from Julia Yates, who is a registered nurse, oncology certified nurse, a master's in nursing, and will soon become an adult and gerontology nurse practitioner. So very well accomplished. Julia is going to speak to us today about an important malignancy, colon cancer. And she's going to give you the statistics about that, as well as presenting signs and symptoms, some of the screening techniques, as well as, for our purposes, the most important thing of what you can do to potentially prevent this. Just a few housekeeping issues. We will be recording this. It will be available on the Cancer Survivors Park website in about 24 hours. I don't know with the Easter weekend whether or not it will be up in 24 hours, but it'll probably be next week. And so if you've been listening and trying to take notes and missed something, it'll be available there. If you have somebody that you feel like the information would be particularly useful for, you can refer that person or those people there. This session will be muted. You'll be muted. We certainly do not want to mute you from the standpoint of interaction with our lecturer, but the chat feature will be available for that, and we will be monitoring the chat feature for questions as they come up. Julia's got a lot of content, so we've got an hour to get this done, and I'm going to turn this over to Ms. Yates, and thank you for all your preparation for this and your agreeing to present.
Thank you, Dr. Jaguar, and thank you to the Cancer Survivor Park Alliance for making this lecture possible. As a career oncology nurse, I'm of course passionate about oncology and cancer care and all types of cancer, but colon cancer in particular has impacted my family and a dear friend. And so I always try to stay current and be an advocate for prevention and screening in this area. What some of you may have realized is that last month was National Colon Cancer Awareness Month. And although it has a designated month, it is really something that we should be mindful of all year long and not just in March. The reason being is that colorectal cancer remains in the top of new cases as well as estimated deaths. So many individuals, when they think about cancer in male or female, they often think of prostate and breast, and then of course lung cancer. But as you see from this graphic, colorectal cancer remains the third most common cancer affecting men and women in the United States. So,
and seems to be the third most common basis for cancer death for both.
right, exactly. So we don't want it to fall off of our radar. We don't want it to not be something we continue to discuss and consider in our own screening. So what is the colon? Some refer to it as the large intestine, even the large bowel, but not to be confused with the stomach or with gastric cancer. The colon, as you see there, is the large intestine and runs the gamut from the connection from the small bowel and through to the rectum. What some folks don't know, and I thought this was of interest, is that it's very common. One of the highest rates of death for colon cancer is in the Alaska Native population. But don't let that confuse you into thinking that it's not something that we as South Carolinians or Greenville natives should be concerned about, because certainly it continues to be a national concern. Here are the numbers for colorectal cancer in South Carolina. So as you can see, there continues to be large numbers of cases, newly diagnosed, and deaths, etc. And what we want to remember is that when caught early is very curable. Colon cancer has generally been considered a cancer of the older population. I know when I was a chemotherapy nurse, the majority of the patients that I would see would be above the age of 55, oftentimes in their 60s or 70s. But in more recent years, we're seeing folks much younger than that. And so while the incidence of colon cancer has declined because screening has gotten better, the mortality is rising in the younger population, and that's likely contributed to the fact that we don't screen younger individuals, and diet is likely a strong contributor there as well, because with each generation our diet becomes much more processed because we're a culture of convenience and we want to grab what's quick, and that's not generally what's most healthy for us. So what are the symptoms of colon cancer? Well, generally there are no symptoms in the early stages. So we don't want to be confused by the fact that, well, if it's recommended that we have a colonoscopy, the fact that we don't have symptoms is not an indication for not being screened. Not having a family history and not having symptoms does not is not a reason not to have screening done. Certainly, if we experience dramatic changes in bowel movements or blood in our stool, or just something unexplained or unusual in the abdomen, then we certainly want to bring that to our provider's attention, regardless of our age. Because again, as I mentioned, early detection saves lives. So when I have people who know that I'm an oncology nurse, they'll often say, well, what's the best cancer to get, or what's the worst cancer to get? Well, all cancers are better when found early. So the key is early detection, the key is screening. And certainly when found at stage 1, the survival rate for colon cancer is very high. While as the staging goes up, the survival rate can drop dramatically. So the key is to find it early before it has spread. Again, because it still remains one of the leading causes of cancer-related deaths.
So Julia, you emphasized the fact that it can be entirely asymptomatic, and the fact that you're feeling well means that does not mean that you can avoid the screening recommendations. But for people, and we emphasize the younger population that are having, maybe some persistent symptoms,
Mhm.
some pain, some bloating, it may be reasonable to discuss that with your doctor and not put that off. And it's also important to make sure that your doctor is hearing you and your concern.
Right.
Because, obviously the doctor's seeing a lot of stomach aches, and it may be a virus or it may be dyspepsia or,
Mhm.
and so they have a lot of things to sort out. But, clearly, if there's a concern about a colorectal cancer or something of that nature, you need to make sure that your concerns are conveyed and that the doctor is listening to you. So there's you getting started with that process, and then it's your partnership with your physician or your health provider that gets you to the point where you probably need to be.
Right. I absolutely agree. And it's all about body awareness and knowing what's different for you. Not everyone's bowel habits are the same, and not everyone's diet is the same. So noticing when something feels different or abnormal, and maybe even kind of keeping a diary or a record of that. And so when you do see your healthcare provider and you're, expressing your concerns, you have some sort of a kind of a documentation about how it's changed and what's made it better and what has made it worse and that kind of thing. And again, you do need to be your own best advocate and be the squeaky wheel that gets the grease, as the old saying goes. Because again, as younger adults, and Dr. Zagier mentioned that that may not be the first thing that they consider,
Right.
but you certainly want to bring it to their attention so that it can then be followed and you can be under some sort of surveillance if the symptoms were to progress. And it also kind of drives the conversation about family history. If someone continues to complain about the same kind of gastrointestinal symptoms, then it may warrant a little bit more conversation about, well, does anyone else in your family have something similar? Is there any cancer in the family? That kind of thing. So sometimes just starting that conversation can lead to a conversation in greater depth.
And along the lines, I think you said it beautifully with regard to self advocating.
Mm-hmm.
It's important that, I think the physician talks to you about your family history when you first get to see them,
Mm-hmm.
and then it's really not brought up after that. Just like a change in your history, there
Mm-hmm.
can be a change in your family history. And so it may not be asked of you, but it's okay to offer that, because it may lead to some kind of a genetic syndrome that would necessitate for us to be a little bit more in tune with doing screening earlier than later.
Right. And a lot of patients will say, I don't know if you need to know this, but I thought I would share this. And so I encourage them to always share information, because it's better to have too much information than not enough. We may not, as non-healthcare individuals, know what is relevant, but it's always good for folks to share all that they can with their healthcare team. So starting with prevention, a lot of folks don't consider prevention through screening. How can I prevent cancer? Well, one of our best ways to be proactive in preventing cancer is through screening. And screening can prevent colorectal cancer through the detection and removal of precancerous growths. It's still the only curative screening tool that we have. A lot of our other screening mechanisms, such as mammograms, are wonderful and continue to detect cancer at very early stages. But unlike a mammogram, a colonoscopy, for instance, can not only detect a precancerous polyp, but actually remove it at the time of surveillance. So that's really an important component of it, because when found early, at an early stage, it's much more curable. So who should consider colon cancer screening? Well, everyone 45 years or older. And this has, the guidelines for this has changed recently. For years now, it has been 50 years or older. Unless you were African American, then it was still 45. But a lot of research has been done and a lot of collaboration between a lot of agencies, the United States Preventive Services Task Force, the American Cancer Society, have come to the agreement that everyone over the age of 45 should have a discussion about beginning their colon cancer screening. And that goes through age 75. And then at that point, it's time to discuss risk versus benefit for a lot of folks at that age. And I have to say, a lot of the patients that I see recently in that age group have an excellent performance status and seem to have very good longevity. So again, it's a personalized care plan to make with your provider based on past history of polyps, life expectancy, et cetera, after a certain age. But if you are approaching the age of 45, you can look forward to having this conversation with your provider soon about beginning your colon cancer screening. And let's talk a little bit more about that. So what are things we need to consider when discussing colon cancer screening? Again, as we just mentioned, age. Are we at the age where that conversation needs to start? What is our risk for actually developing colorectal cancer? Do we have a family history? Do we have our own personal history of inflammatory bowel disease? Do we have Crohn's or ulcerative colitis, or is there a family history of that? There's a lot of things to consider that contribute to your risk. And also there's the risk of the procedure itself. There are folks that the anesthesia, the procedure, the prep may not be something that you and the physician think is best for you, but as we'll discuss in a moment, there are alternatives, there are options. And then, a lot of people are concerned about discomfort and following through with the test itself. And then, will they be able to afford it? And can they take the day off? There's a lot of things to consider there as well. But as I mentioned, there are a lot of forms of screening. Colonoscopy continues to be the gold standard, but there are other options to be discussed with your healthcare provider. There are now stool tests that can be done that can detect DNA. There are stool tests that are very preliminary that can just detect blood in the stool, which may lead to a further workup. For some patients, even doing a virtual colonoscopy in the form of imaging is an option as well.
A virtual colonoscopy.
So starting with the colonoscopy, which again is the gold standard, when you have your first screening colonoscopy, unless you are at high risk due to a genetic mutation, which we'll talk a little bit more about, or a first-degree relative with colon cancer, unless you're deemed a high risk for colorectal cancer, your screening colonoscopy, if results are normal and without polyps, you are generally cleared for 10 years. We can't say the same for mammograms and other screening that we generally undergo. So if you're cleared by your physician following the colonoscopy and no polyps are found, no cancer is found, then you may be clear for 10 years. Again, with just the thought of doing a bowel prep, I know I talk to patients often about that or ask them why that they're behind on their screening when they're past the date of eligibility. And they seem to be most concerned about the prep. And I can say, as someone who's had several colonoscopies, I share their anxiety about that. It's not a pleasant experience, but we have certainly gotten better with the prep over the years. And there are several options. There are low volume options and the higher volume options. But in preparation and planning, It can be something that is very manageable, very tolerable. And again, on the date of the exam, the anesthesia is generally well tolerated and the procedure you're not aware of. So it's really not a difficult procedure once you make it through that night of prep. And again, you can be very proactive in the preparation the day before, in having clear liquids and those kinds of things. And if you're prone to constipation or you're prone to irritable bowel and those kinds of things, again, that's a conversation to have with your provider about your apprehension or your reluctance. And then you can kind of come up with a plan that makes you more comfortable with the preparation. And then going back to, the coverage for it, a lot of people would be concerned about that. This is just something that's offered in a lot of the literature about what Medicare covers, but whether you're on Medicare or you have private insurance, that's a conversation to have with your insurance provider about what they cover as far as screening. But again, for generalized screening, it's usually covered, and then based on the findings of your initial scope, then the coverage, will be dictated going forward. And once you have a test, any type of endoscopy procedure, whether it be a colonoscopy or a flexible sigmoidoscopy, which is coming up in a few moments, the really vital important is to know the important fact to know is to know your results. So oftentimes you'll come out of a procedure and the doctor will tell you that everything was fine. And of course, you're also in recovery, and so you're kind of still coming out of anesthesia. But what you really want to get details on is what exactly was found. Sometimes the pathology report is not available until a couple of days or a week. You may have a virtual visit with your provider after the colonoscopy, or you may come in to review the results. But it's good to know for your family and for yourself what kind of polyp was found, what size, how many total were found, and the most important thing is when do we need to repeat screening, because that's going to be based on the findings. Again, if it's normal and there are no polyps, no cancer, then the general recommendation is 10 years. If you have multiple polyps, or if you have a pre-malignant polyp, an adenomatous polyp, a large polyp, then you're likely going to have more frequent screening or surveillance. And if your prep is not good, you may be rescheduled to repeat that. So another good reason to really, once you make the proactive choice to plan and schedule your colonoscopy, to take that preparation seriously as well, so that you know that your prep is successful and your colon is clear. That makes for a better procedure, more successful procedure.
And just to emphasize, I mean, we're in an era now where we pretty much disclose all of the results, the procedure results, the path results, all those things are available on interfaces like MyChart.
Right.
And so, keep records of that. I mean, we're a mobile population. You may not be seeing the same gastroenterologist. That gastroenterologist may retire or move, or your insurance may dictate that you should go to another healthcare system. So there's lots of reasons why, again, in the sentiment to be self-advocate, that you keep these path results, because adenomas, polyps, I mean, there's different things, there's different wordings there that make us consider things more serious than others.
Right.
So again, self-advocacy by keeping track of the results of the colonoscopy. You went through the prep, you went through the procedure, you might as well take the results and have those available as information for the future.
Right. And share that information with family members, because as we're going to talk in a moment about the importance of family history, once you start your own screening or you're being evaluated for your own risk, what's always of interest to your provider is, do you have a family history of polyps? Now, I know we don't generally have those discussions with our parents, our grandparents, our siblings, but as people become more informed and more proactive, we are starting to kind of have those conversations. So if your mom or dad or your sibling says, well, I've got to have my colonoscopy on Friday, then it's a good idea to ask how that went. If there's anything, that they can share from that may be, relevant to your own risk. And that was a good point, Dr. Jaguar, about how the results are often released into the patient portal. So, don't hesitate once you get those results, if you have questions, to ask your provider. This was just another one of the options for surveillance. And again, it's a conversation to have with your provider, whether you have a full colonoscopy versus a flexible sigmoidoscopy. The colon is divided into 4 sections, and the sigmoid, the ascending and the sigmoid colon are here. And so this procedure is done more frequently, but may be a better option for some patients.
And it doesn't require quite the prep.
Exactly, right, because they're not having to go all the way through the entire colon.
This does require quite the prep.
The CT,
Yeah.
right. So you can see from the imaging how important it would be for that to be clear, so that they can see air versus any type of masses or polyps. And this is not the most common of the exams that are offered, but certainly an option just the same. And then, of course, the stool test options. A lot of us have seen the commercials, and this is really more indicated for those folks who are at average risk. And if you had a family history, if you had a personal history of polyps, or a family history of colon cancer, and especially a family history of genetic mutations, then the stool test screening is not indicated for you. This is for folks who are at average risk. And a lot of folks would ask, well, what's the best option for me? What's the best colon cancer screening option? And really, the best option is what an individual is willing to do. So if you are unable or unwilling to do a colonoscopy, then there are other options. And again, to discuss it with your physician, because if you have a Cologuard or one of these stool tests and it comes back positive, the recommendation is going to be to follow through with an endoscopy or colonoscopy. So if the stool shows signs of DNA that indicates a potential malignancy, then they're going to want to go in with a colonoscopy. So there's no guarantee that doing the stool test is going to completely get you out of that type of surveillance, but it is an option.
And understand that the stool is being evaluated for some DNA that may be sloughed from not only a malignancy, but also from a polyp.
Right.
And so it may not be, if it's a positive test, something that is, truly designated a cancer. But along the way, also having a negative test, while reassuring, is not necessarily the situation without a colonoscopy that implies that it's a true negative.
Right.
But
And there's a lot of variables. I mean, it is a stool collection. It's collected at home. There are a lot of things that could potentially, impact the results. So a lot of things to consider there. Not every patient is a good candidate for doing that type of procedure at home.
But science is definitely working in our favor. We were doing some clinical studies looking at blood DNA and having that correlate with colonoscopy as well. So We're getting better at determining that, but colonoscopy, I have to say, is not going to go away as the gold standard test for making a diagnosis, finding out, if we have a malignancy, where it is, and at least starting the staging process.
Right. And remembering that it represents direct visualization. So, essentially they're going in with a scope and a camera to actually see the inside of your colon. You just can't get any clearer screening than that with a good prep. So we're kind of circling back around again to the risk factors for colon cancer. And because age is a factor, and of course race as well, as I mentioned before, African-American population is at higher risk. And then of course having a family history of colon polyps, which we're not going to know if we don't ask or we don't offer that information to our family members. And then the family history of colon cancer. And sometimes you don't know that your family member had colon cancer, but maybe you know that your grandfather had a colostomy bag and you're not really sure why he had it. That's something that you can just share with the physician. They may not be able to, definitively say that's what happened, but that's relevant information to share, because for some reason that family member had a portion of the colon removed. So that's always good information to share. Share as much of the history as you have, because you never know what's most critical. And when you're sharing the family history of colon cancer, also knowing at what age they were diagnosed as closely as you can give. And oftentimes that's very difficult to ascertain or to get from family members. But sometimes you can get an idea if it was while they were having a family, after their family was grown, just kind of getting an idea of what decade of life that happened for someone. That can be helpful information. And then again, the personal history of inflammatory bowel disease. Those of us that have Crohn's disease or ulcerative colitis, they're at higher risk for developing colon cancer. So the surveillance is a little bit different. And then of course, genetic syndromes such as Lynch syndrome, which is a syndrome that is a hereditary non-polyposis colorectal cancer syndrome. And that's just a big explanation for a syndrome where genes that our body has, our body is an amazing machine that has its own mechanisms for protecting us and for preventing cancer. And so some of those genes that actually are there to help protect us, when they are mutated, then cancer is allowed to develop when those genes are not working properly. So if someone in your family has a gene mutation in a specific set of genes and they are designated as having Lynch syndrome, then they're at risk for multiple cancers, and one very specifically is colorectal cancer. So if you ever hear anyone in your family mention Lynch syndrome, then you want to get more information about that, because that is relevant information for you. And then of course, other risk factors include our diet. Processed meat is what a lot of folks don't understand is classified as a group 1 carcinogen. So it is highly carcinogenic and in the same category as carcinogen as tobacco. And we'll talk a little bit more about that. So we just need to be mindful of those things that we take in, as well as alcohol, tobacco, managing our weight, because having excess body weight contributes to 12 different cancers, including colon cancer. So that's one way in which we can be proactive in lowering our risk. And then of course, being sedentary is a contributor to our risk for colon cancer.
And just to circle back to Lynch syndrome, one of the other malignancies that's common with that is a GYN malignancy, specifically endometrial cancer. So if there is a family history of uterine cancer, that may be an important thing to talk to your doctor about as well.
Right. And that's why having a full family history is so important, because we don't expect the general public to understand that in some genetic mutations, prostate and breast and melanoma and pancreatic cancer are linked in that mutation. But if you just give a full family history, tell us all the cancers that you're aware of in the family and the age, and then your providers can kind of help tease that out. And if they feel like you're at risk, then genetic counseling may be recommended, and they can do a more full consultation to stratify your risk. It's really important to recognize if you have a first degree relative, and that includes mother, father, full siblings, and children. And also to let your provider know if you're adopted when they're taking a full history. That's really important to know. It's important to know what you know as much as what you have no knowledge of. And going back to the polyps and what kind they are, a lot of times we're not familiar with these terms, but again, if you get a copy of your report of your colonoscopy and you find that you have an advanced adenomatous polyp, such as the ones listed here, tubular adenoma, and there's tubular villus adenoma, and a sessile serrated polyp. So those are features or characteristics of polyps that we may not be familiar with, but your physician and the pathologist looking at those polyps are, and those are generally indications of a higher risk for colon cancer. So you want to be aware of those and share that information with your family, so that they can make an informed decision about screening. That's the most important thing. We have the choice to choose what and how we proceed, but we want everyone to be able to make an informed decision. And this is just a great reminder that cancer prevention is any action taken to lower the risk of getting cancer. So one action that we've already discussed is screening. That's a very important action to be taken to lower our risk or to prevent cancer. But what a lot of people don't realize is that just important and even more in our power is our lifestyle modification, how we spend our time, what we eat, how much we move. Our risk of developing all types of cancers, including colon cancer, are impacted by those. And nearly 50% of the most common cancers can be prevented simply by maintaining a healthy weight, being physically active, eating a good plant-based diet. And that doesn't necessarily mean a vegan, vegetarian, pescatarian diet. It means being mindful of, with whatever lean protein that you choose, having those fruits and vegetables, legumes, beans, those really excellent plant sources that have phytochemicals. And those phytochemicals are compounds that actually have the power to protect us in many ways and lower our risk. And limiting alcohol consumption is also a very good lifestyle modification to consider to lower your risk of cancer. And this just kind of goes back, this is a graphic that kind of goes back to what I mentioned about processed meats, and that it's a classified group 1 carcinogen, which is the same group classification as tobacco. So while a pack of hot dogs may not have the Surgeon's General warning on the side of it, we just ask that you be mindful when you're in the supermarket and think about the way I like to educate my cancer prevention study participants is that if you think about what happens between the pig and the package, all the time that's taken to prepare that animal to be preserved and packaged up so that it has a long shelf life. Just imagine all the preservatives and salts. Nitrates and nitrites are those components that impact our risk. So looking in the supermarket for those items that may be nitrate, nitrite free, the healthier versions, is a better alternative, although, you know, the jury is still out on whether or not that you know, eliminates your risk, but it certainly improves your risk. But the goal is just to avoid processed meat. And then red meat, which people often avoid due to cardiovascular disease or obesity or what have you, it poses its own degree of risk, but at a lesser level. And so red meat can be consumed at 18 ounces a week, whereas processed meat, bacon, salami, sausages, hot dogs, everything that's on a charcuterie tray essentially is something that you really want to limit consumption on.
That hurt me.
I know. And here's another really good visual aid, an infographic, if you will, about how, you know, regular consumption of processed meat greatly increases your risk of colorectal cancer. And a lot of folks, as I'm counseling them on processed meat, will go down the list of items and say, well, I don't eat much bacon and sausage and pepperoni and salami, but then they'll hit luncheon meat and realize, oh, well, I do have a turkey sandwich every day. So just to be mindful of the source of that turkey sandwich. Are you cooking your own turkey breast and slicing it? Is it a good?
So Julia's frozen. Normally they come out of this. So we'll just kind of fill in for the time being. Julia, you back? Anyway, one of the things that we want to emphasize is that colorectal is a very common cancer. It's a very common cancer we deal with. It's about 5 feet of our body, but it is a common place where we get malignancies, and it's a common place where oftentimes the malignancy translates into mortality. So it is a situation, however, that we do have tools, and we're getting more and more tools from the standpoint of screening capabilities, some of which are less invasive than the gold standard. And maybe something, I think Julia made a great point about the fact that the most effective screening test is the one the patient will do. And so more and more capabilities. And then we're also not, even if we're at risk for colon cancer and we have polyps, we're not.
Are we back?
A sitting duck. Yeah, I'm just kind of summarizing. Just I
Okay.
felt like I needed to keep things going here.
I'm not sure what happened.
Technology, but just from
Right.
the standpoint of the things you were talking about prevention wise, we're not a sitting duck. There's some proactive stuff you can do. And
Right.
Julie's given those tidbits, and she's going to go into that further.
Right. So the American Institute for Cancer Research is a great resource that we have begun to utilize a lot in our Center for Cancer Prevention and Wellness. They're a wealth of information and resources. The website gives a lot of education, and it kind of covers the top things that we need to focus on. And a lot of this is not, as I say, rocket science. Many of us know and have known for years that we should try to maintain a healthy weight, be active, avoid drive-through windows, not to use tobacco products, not to drink excessively, and so forth. So, but there is data to support all of that. And there's an expert report that is periodically published that just reinforces why this is all so important in the act of cancer prevention. And again, there are a lot of resources online. I would encourage anyone who might be interested in looking a little further into those resources. The AICR, or American Institute for Cancer Research, that's AICR.org, offers a lot of information, even has cancer prevention recipes. And that's where we get a lot of our resources from. And one of the ways in which we've been proactive in our health system and in our Cancer Institute is by developing a cancer prevention study. Prevent Cancer Greenville is the name. It's on clinicaltrials.gov, and it's available to anyone 18 years or older who speaks English. Only because we're not able to support all languages now, but we hope to in the future. So any consenting adult who would like to come in for a free annual visit, fill out a 25-page questionnaire all about your family history, your diet, your activity level, things that you've been exposed to, and allow us to complete a summary of recommendations for you. We also do a body composition measurement for free that allows us to give you more information on your actual body fat, so that you can make informed decisions there, because oftentimes it's hard to go by just our weight or what size we wear. We want to know what the actual composition is so that we can, make decisions based on, do I need to lose fat or do I need to build more muscle? Because the body composition also gives you information on that. But even more importantly, not only is our goal to educate, but also to take donations of biospecimens that'll help us in the research going forward. So within this cancer prevention study visit, we do collect 2 tubes of blood, a urine specimen, and a cheek swab, which is just a Q-tip rubbed on the inside of the cheek, thereby collecting the epithelial cells. And those specimens are banked annually with the goal over the long term to, with time, be able to detect changes in the DNA and the RNA and the proteins over time that may be precursors to malignancy. Because we know that cancer begins to develop long before it is found, oftentimes on a mammogram or a biopsy. And so how can we find that sooner? And how can we then correlate it to our own lifestyle or exposures? So we currently have almost 800 people enrolled in the study, and it's just a really good opportunity to have more of a discussion about your own personal risk, what kind of screening would be recommended. And
Well,
Okay.
and I want to make it clear that 25 pages is not overly daunting.
right.
And that it is completed pretty easily.
Yeah, so Monday
And
is,
there are annual follow-ups
the
so that
18th, and what
the
I'll do is,
prevention
Tuesday,
advice that you
I'll
get
come in
and
Tuesday
some of the
morning.
feedback you
Well, that's
get from your
Thursday.
body composition and
I think I
whatnot
get back in the middle of the day on Monday.
is something
Maybe
that
I'll
you
come
can
in
look at
Monday
year to year to see
sales
whether or
tax.
not you're improving with the interventions
What
that
I'm
they're
doing right
recommending.
now is giving you all the
Right,
checks that need to be
right.
mailed.
So it's
Uh,
all designed to just kind of help folks
The documents.
set healthy
Then
goals
after
for
that, I log
themselves,
in
and
submit the
also to ask
So the
questions about their
20th
own
is
personal risk and
Wednesday.
if
So if
genetic
I
counseling would be
come in
indicated, that kind of thing.
for that, obviously,
So we
I
have
can do
one
it on
person that
Friday,
is
but
giving
Not
us
muted.
background noise that needs to mute herself. Thank you. So these phone numbers and this website is available if you would like to participate. Obviously, of those almost 900 people, a lot of those are white females. So we need to have more of a representation of our population to include males as well as African-American females and males.
Absolutely.
To have a complete picture of what Greenville and Prevent Cancer Greenville should mean. So we've had a pretty quiet chat room. I will tell you, Julia, that was as complete and all-encompassing a story of colorectal cancer, its screening and its prevention as I have seen. So I congratulate you on that. I think we have made it clear that it's not a static field. It's constantly dynamic. We could probably have you back in 18, 24 months and you'd have a lot of new information to impart to us.
Right.
So, but it's a really important cancer, but it gives us tools, both in screening tools as well as in prevention tools.
Right.
So any last words? And if not, I'll let you get on with Easter.
Well, I don't want to leave without saying that that again, as a career oncology nurse, I have had the pleasure and privilege to care for a lot of colon cancer survivors. And countless times they would say to me, I wish I'd just had the colonoscopy that my doctor had recommended. So I just share that because those folks who may be apprehensive, that's understandable and it's not uncommon. But I just encourage you, instead of avoiding the screening, just to have a deeper conversation with your provider about it and what the options are, and just strongly consider having a screening colonoscopy if you are eligible or possibly past due.
Great advice. So we will be back with you in a month. And that'll be May 12th. It's the second Thursday in May. And this may be one that we really, really want to advertise and make sure we have all generations involved. This is going to be Dr. Heather Brandt, who's the director of the Human Papillomavirus Cancer Prevention Program at St. Jude's Children's Research Hospital, which I suspect everybody's heard of. As you know, human papillomavirus is associated with cervical cancer. In fact, there's no cervical cancer that's not created by human papillomavirus. And there's that virus is also associated increasingly with oropharyngeal throat cancer as well. One of the things that has developed is we have now a vaccine that is administered to youngsters to prevent the papillomavirus from developing. Now, I think that the vaccines were a little less controversial before COVID happened, but it still is a situation where a continent / country in Australia is working towards vaccination for the total eradication of HPV in that subcontinent, in that continent, in the country. So it is a very effective vaccine, and it'd be worth your while to kind of communicate this to not only your friends, but your children, your children's friends, because it's information that can make a huge difference in the cancer burden with regard to cervical and oropharyngeal cancer. So that'll be May 12th, and there'll be more to come on that. And we just kind of end with a quote. This is from Hafiz, who's a Persian poet in the BC era. And I think it's probably also apropos for the weekend we're about to impart on. And the quote is, "I sometimes forget that I was created for joy. My mind is too busy. My heart is too heavy to remember that. I have been called to dance the sacred dance of life. I was created to smile, to love, to be lifted up, and to lift others up. O sacred one, untangle my feet from all that it snares. Free my soul, that we might dance and that our dancing might be contagious." So everybody have a happy Easter weekend, and we will see you next month. And please visit the Cancer Survivors Park. The goal and mission of the Cancer Survivors Park Alliance is to make life for cancer survivors better and more fulfilling. And we're all about preventing this disease when we can. And so much of that is about lifestyle changes. So look into the chat room. There are no other questions. So we will sign off, and thank you all for attending.
Thank you.
Thanks, Julia.
Mhm.